Here we go. Can everyone see that?
Yep.
Okay, can you hear me?
Yes.
Okay, perfect.
Yes.
Okay, my name is Karen Penta, and I'm here with Dr. Howard Hernandez. Both of us are members of the Transformation Care Network. We hope that it will help you feel more comfortable by experiencing this training and treating this population and providing a framework for providing care for those patients who experience psychosis. This presentation will last approximately 1 hour. We will provide our information to you, and we will leave a few minutes at the end to answer any of your questions. Should questions arise throughout the training, please feel free to enter them into the chat so we can address them during that time. Again, Karen Giuliano explained how you will get credits for either CEUs or CMEs, and that form will show up in the chat just about the time we start our questions. Howard?
Thank you, Karen. For conflict of interest, the speakers have no relevant financial relationships with commercial interests related to this presentation, except to our spouses, right, Karen, who support us fully. Though chocolate and strong coffee have been known to bias our decision-making process.
Yes, sir.
Okay.
So I'm here with Dr. Hernandez. Dr. Hernandez wears a few hats. He's a psychiatrist, an Army major. He participates in the Boston Marathon. And yes, he's even a hospital clown. He's board certified in adult, child, and adolescent psychiatry. He was trained in the Philippines, Cleveland, and Boston, and now practices integrative psychiatry at Cape Behavioral Health Center. He is the lead psychiatrist on the CAPE's interventional team. When he's not working on trauma-informed care or supporting the LGBTQ+ community, he's raising money for healthcare causes, usually while running very long distances. Above all, he's known less for the titles and more for his compassion, community spirit, and occasional bad clown jokes. He's an integral part of the TCN team and well respected by his colleagues and patients.
So kind of you, Karen. Now it's my turn. Karen, our speaker, currently directs our outpatient mental health services here at Cape Behavioral Health. She's led clinics across Massachusetts, worked on everything from deinstitutionalization projects with DMH to trauma-focused therapy with kids and families, and spent 2 decades in nonprofit leadership at MSPCC, that's the Massachusetts Society for the Prevention of Cruelty to Children. In other words, if there's a tough mental health challenge in the community, she's probably rolled up her sleeves and worked on it. Officially, she's a master's trained licensed counselor with expertise in trauma and childhood disorders. Unofficially, she's just the person you want to hang around with if your team needs a steady leadership or just someone to schmooze on your lunch breaks at the clinic.
I like that. Okay, so the learning objectives for this course is to understand the core features of psychosis, identify classes of medication for treatment, and recognize evidence-based approaches to treatment. Also learn about essential outpatient services and supports, and build the confidence and skills to work calmly and effectively with people experiencing psychosis by recognizing symptoms, using supportive communication, and maintaining safety while reducing fear and stigma.
Yeah, very important indeed. This presentation provides a brief overview of psychosis, integrative psychiatric treatment of psychosis, and a collaborative framework for outpatient treatment of psychotic disorders.
So before I go over the core features of psychosis, it's notable to note the incidence of schizophrenia in the general population. So the prevalence of psychosis in the general population, a lifetime prevalence of any psychotic disorder, about 3% of the population. The point prevalence at any given time is around 0.4 to 0.7%. For schizophrenia alone, it's 1% in a lifetime and has a point prevalence of 0.3 to 0.5%. That means About 1 in 100 to 1 in 200 people may develop schizophrenia at some point in their lives. Onset of these disorders most often appear in late adolescence or in young adulthood. Yes, schizophrenia has a genetic predisposition, but it usually becomes apparent with certain environmental triggers or factors such as trauma, stress, substance abuse, physical or emotional abuse, or other environmental stressors. So, psychosis features one or more of the following key symptoms. Delusions. So delusions are fixed false beliefs not shared by others in the culture. Hallucinations. Sensory experiences without external stimuli, often like auditory or visual, can be tactile, somatic, olfactory, meaning the sense of smell is tested, or even gustatory, meaning affecting the sense of taste. In summary, hallucinations can affect the sensory system. The most common psychiatric illness is auditory, while visual and tactile are usually typical in medical, neurological, or substance-related conditions. Other common features of psychosis is disorganized thinking, where a person becomes incoherent, or also experiences derailment, like when a person's ideas sort of slip off track onto an unrelated or loosely related topics, making conversation very hard to follow. We call that tangential speech. There's also grossly disorganized behavior, which it often becomes unpredictable, purposeless, or severely disruptive. Also, catatonia, which often ends up in severely reduced movement, sometimes even bedridden. Negative symptoms are typical, like diminished emotional expression, flat affect, avolition, which is a lack of motivation, or anhedonia and social withdrawal.
Okay. The major DSM-5 psychotic disorder categories are the following. So just to run through: schizophrenia, schizophreniform, brief psychotic disorder, schizoaffective disorder, substance-induced psychotic disorders due to a medical condition, and other specified. DSM-5 organizes psychosis along a spectrum, ranging from short-term, such as the brief psychotic disorder, to chronic schizophrenia, and distinguishes between primary psychotic disorders and those secondary to substances or medical conditions. Schizoaffective disorder bridges psychosis and mood disorders. To note. Next slide. As a provider, my approach is grounded in 4 core principles of integrative psychiatry when treating psychosis. Number 1, conventional treatment first, antipsychotic medications, which I call actually neuroleptic medications, to sometimes remove the stigma. They're essential for safety and efficacy, and they form the foundation of our care. Number 2, whole person approach. Medications aren't enough. We take a whole person approach that addresses not just biology, but also psychological, social, and spiritual dimensions of health. Third, for adjunctive supports, we then add pharmacological strategies such as psychotherapy, lifestyle interventions, peer support, family work, and community engagement. These promote recovery, reduce relapse, and improve quality of life. Fourth, individualized care. Care individualized. That treatment is tailored to the patient's needs, values, and cultural context. So it's both clinically effective and personally meaningful. In short, integrative psychiatry doesn't replace conventional care. It builds on it to support recovery in the broadest and most human sense. When starting treatment for psychosis, the first medications developed were the first generation antipsychotics. Some examples include haloperidol, fluphenazine, and chlorpromazine. These medications work by blocking dopamine receptors, especially D2 receptors the brain. This reduces the overactivity of dopamine in the mesolimbic pathway, which is thought to cause the positive symptoms of psychosis, like hallucinations and delusions that Karen elucidated earlier. Because they strongly block dopamine, they also affect pathways where dopamine is important for movement and body. That's where we see the side effects. Side effects such as EPS, extrapyramidal symptoms, which include muscle stiffness, tremors, restlessness, slow movements. In a patient, this may look like Parkinson's disease if it's chronic. It can be shuffling. You can see shuffling walk, a rigid posture, and tremor. Tardive dyskinesia are involuntary movements, especially of the face, tongue, and lips. Patients may have lip smacking, grimacing, and tongue movements, which they can't control. NMS, neuroleptic malignant syndrome. This is a rare, life-threatening reaction. It looks like a very high fever, muscle rigidity, altered mental status with unstable vital signs. Note that this is an emergency and requires immediate treatment. So in summary, first-generation antipsychotics are effective at reducing positive symptoms, but they may come with significant motor side effects because of widespread dopamine blockade. Recognizing what these side effects look like in patients is critical for safe prescribing. Second generation or atypical antipsychotics. Examples include risperidone, olanzapine, quetiapine, aripiprazole, and clozapine. Now, these medications work by blocking both dopamine and serotonin receptors. Sometimes I call these medications serotonin, dopamine, or dopamine serotonin modulators, instead of antipsychotics. So this dual action of the dual action of serotonin and dopamine blockade controls psychotic symptoms while reducing some of the movement side effects seen with the older drugs. So if you compare to the first generation, the benefits are lower risk of motor side effects like tremors, and they can also help with mood symptoms, which make them useful in bipolar disorder and schizoaffective disorder. However, they carry their own risks. Weight gain and metabolic issues like diabetes, high triglycerides can happen today, which can affect daily functioning. So second generation antipsychotics, to wrap up, give us a broader symptom coverage and fewer movement problems, but we need to watch carefully for metabolic side effects. Next one. Special mention to clozapine, which is an atypical second generation antipsychotic. It's unique because it's the only medication specifically indicated for treatment-resistant schizophrenia and for recurrent suicidal behavior in schizophrenia and schizoaffective disorder. Now, clozapine works broadly. It blocks dopamine, serotonin, norepinephrine, and histamine receptors. This wide receptor profile is what gives it its strong efficacy, but also its side effect burden. Because clozapine can cause agranulocytosis or dangerously low white blood cells, excuse me, it requires regular CBC blood tests. Patients are enrolled in a registry to ensure ongoing monitoring. So beyond blood counts, clozapine has other serious risks of too, like seizure at higher doses, myocarditis, which is the inflammation of the heart muscle, severe constipation can be life-threatening if untreated. In summary, clozapine is one powerful antipsychotic reserved for patients who haven't responded to other treatments, but because of its risks, it requires careful monitoring and a high level of clinical vigilance. Next slide. The long-acting injectable LAIs, antipsychotics. So there are examples here for first generations, haloperidol, fluphenazine. For second generation, risperidone, paliperidone, olanzapine, aripiprazole, So the goal of long-acting injectables is threefold, right? First, they improve adherence since the patient doesn't need to remember daily pills. Second, they reduce relapse and hospitalization by keeping levels steady. And they third, they provide consistent blood levels of avoiding the peaks and troughs we sometimes see with the oral dosing. Okay, next slide. Before this one, for practical pointers for injectables, sometimes they require an oral overlap period. For example, risperidone or proprazole, while others don't. Just know that we do that in practice. In addition to the well-established first generation, typical, and second generations, atypical antipsychotics, there are several newer agents, sometimes we call third generation antipsychotics, that have been approved more recently. They tend to work as dopamine partial agonist stabilizers and often have broader receptor profiles. Next. Next, please. So we go to the phases of antipsychotic treatment. There's the acute phase, approximately first 4 to 8 weeks. In the acute phase, the goal is rapid symptom control. This often requires hospitalization for safety and stabilization. We use short-acting antipsychotics, either oral or intramuscular, sometimes even dissolvable orally, and sometimes short-term benzodiazepines if there's severe agitation. The stabilization phase, which is in between, depicts early recovery over several months usually. So once the acute symptoms are controlled, we move into this phase and this early recovery period where the treatment focus is maintaining improvement, building adherence, and gradually reintegrating the patient into daily life. The maintenance phase, finally, we enter. This can last for years or even lifelong. Here, the provider's goal is to prevent relapse and improve overall functioning, always using the lowest effective dose of antipsychotics to balance efficacy while minimizing side effects. Karen?
Well, and now I'm going to describe a framework for treatment of psychosis for clinicians. Can't really talk about that much until we talk about the history of treatment for patients with psychosis. It wasn't until the 1960s that patients with psychosis were even actually treated in the community by clinicians. Most patients prior to that decade were housed for long periods or even up to a lifetime in what was called asylums or sanatoriums. Those facilities transitioned to hospitals funded by state and federal governments. It was the work of mental health advocates, public policy professionals, politicians, and prominent psychiatrists and social workers who worked diligently to begin the process of deinstitutionalization. In 1963, the federal government passed a landmark legislation to shift the focus of mental health treatment from very large institutions to community-based services. This piece of legislation was signed into law by John F. Kennedy. It is now the framework by which we provide access to care in the community for those patients with psychosis. So, ensuring early intervention is key for positive outcomes. Clinicians should diagnose and refer promptly to a med provider once meeting with a clinician that they suspect has psychosis. As mentioned before, these symptoms arise in adolescence and young adulthood. So there may be a teacher or an employer that recognizes these symptoms and may call for help. These people need to be brought in as soon as possible and referred for medication management. Also, the clinicians can make sure ensuring that placement and support, proper placements and supports are in place. That means making sure patients are in the right placement, working closely with family and community resources so they can maintain regular treatment visits. However, oftentimes times patients fall through the cracks, end up in the hospital, and are sent to homeless shelters where if they don't have family or any supports. At this point, it's important to refer to a coordinated special care team like the subcontractors of DMH, for instance, Fellowship or VinFin. They're there when families can't be. They provide ongoing oversight of the client and making sure that all their needs are being met, or at least trying to. Often families must rely on DMH and subcontracted providers to deliver intensive case management because they can't be there. It's also essential for long-term stability. Clinicians can also provide family therapy and psychoeducation if families are involved. Families play a huge role. We want to provide education, therapy, and make sure representative payees or guardianships are in place if need be. Oftentimes, these patients have difficulty managing their own affairs or money management. Families need to understand the illness is lifelong, and planning for patients long-term is vital. Once these basic supports are in place and the client is relatively stable, clinicians should implement evidence-based practices like CBTP, which we'll discuss shortly. That helps patients commit to their treatment goals and address irrational thoughts or behaviors in a supportive framework. Patients, families, group homes, caretakers should always have access to numbers for crisis and emergency services for 24/7 response. So I promised I'd talk a little bit about CBT for psychosis. Cognitive behavioral therapy, or CBT for psychosis, did not have any simple founder like other evidence-based practices. It evolved over time with lots of therapeutic contributors. However, a key contributor, Aaron Beck, who was the father of general CBT, laid the groundwork. Other researchers began clinical trials in the 1990s and 2000s showing CBT had promise and could help patients with psychosis manage their symptoms. There are some commonly used manuals outlining this approach that you might want to look into. They're outlined in the resources. It's like the CBT therapy for schizophrenia by Kingdon and Turkington, and CBT for psychosis written by Morrison, Renton, and Dunn. So a typical intervention of CBTP would be first targeting psychosymptoms by helping patients understand and reframe their experiences. It helps patients challenge distorted or unhelpful beliefs and teaches practical skills to reduce impact and improve their daily functioning. For instance, hallucinations. Clinicians can help patients understand that hallucinations are a known symptom of psychosis, and other patients with psychosis experience them too. This helps reduce the feelings of isolation and being alone. Clinicians can explore triggers and patterns when they occur, and they are taught techniques to manage distress, for example, hearing voices by using reality testing or distraction techniques to lessen impact, like listening to music. Delusions, which are strongly held beliefs. These symptoms can be targeted by the clinician helping build trust and collaboration with the patient by not immediately challenging the delusion. Instead, they build a partnership and explore the belief in a gentle manner to try and understand its origin and how it had served the patient. Over time, the clinician introduces questions that help the person consider different beliefs, alternatives to their current beliefs, finding other ways to interpret them, thus reducing the overall distress of delusion, even though it really never fully goes away.
Thank you, Karen, for explaining to us what CBTP is.
Yeah.
Now, when we think about optimizing treatment for psychosis, the foundation is always to use the lowest effective dose of antipsychotics or neuroleptics, and to consider long-acting injectables if adherence is a concern. There are adjunctive options. There's growing interest in nutraceuticals and supplements. The evidence base varies, but here's what we know so far. Omega-3 fatty acids with EPA and DHA. Some benefit has been shown in early psychosis and possibly in preventing relapse. N-acetylcysteine, or NAC, is an antioxidant that has been studied for its role in reducing negative symptoms. Vitamin D, B complex, folate, especially the L-methylfolate, if low, zinc. Now, correcting these deficiencies may support better outcomes, particularly in mood and cognition. An exciting area of research, though still emerging and not standard of care yet, would be probiotics, prebiotics, and how it relates to gut microbiome and gut-brain axis. Next slide. Yeah. Lifestyle medicine. Psychosocial and complementary interventions, known as lifestyle interventions, they certainly play a huge role in recovery and relapse prevention. Medication is the backbone of treatment, but non-pharmacological strategies are critical to recovery and their quality of life. Here are a few that we have evidence behind them. So nutrition, we emphasize a whole food, plant-based, Mediterranean-style diet, which supports cognition and metabolic health. A friend of mine, Dr. Chris Palmer, is setting up a clinic in Wellesley, and I think he's also going to give the ketogenic diet, purely to induce ketosis, which has been also been known to help these types of patients. In a way, metabolic health is mental health, and mental health is metabolic health. So with nutrition, going back, we try to limit processed foods, excess sugar, and pro-inflammatory foods, fats, especially important given the metabolic side effects of some of the antipsychotics we mentioned. Exercise. What we're doing here in Hyannis at Cape Cod, we're actually giving exercise prescriptions now to our patients using the FIT model. Like to quantify, I ask the frequency, intensity, type, and timing, and then we check on and monitor them in future sessions. Regular aerobic and strength training improves mood, cognition, and sleep, and helps reduce weight gain and other metabolic effects. Mind-body practices such as yoga, tai chi, qigong show benefits for mood, sleep, and some of the negative symptoms. I think they also would give the patient a chance to socialize if it's a group, or a sense of control in their recovery when you utilize these mind-body practices. Good sleep hygiene certainly is essential. Circadian rhythm disruptions can actually precipitate relapse. So maintaining regular sleep patterns is critical. Some sunlight exposure for the photoreceptors of the eyes to make the hormones be in sync. And finally, stress reduction. So meditation, the power of the breath, breathing exercises, grounding techniques, they certainly help stress reactivity, which can otherwise worsen symptoms or trigger relapse. So using mindfulness-based approaches, our patients can improve coping with their voices or intrusive thoughts, combined with medication, may help reduce relapse. So in essence, nutrition, exercise, sleep, and stress reduction aren't just add-ons. They're actually core components of holistic care for psychosis.
Thank you, Howard. So I want to talk a little bit about social and environmental supports. Recovery in psychosis isn't just about managing symptoms, it's also about improving function, relationships, and the quality of life. These supports are key. Teaching families how to support their loved ones and helping them to recognize early warning signs can significantly reduce relapse rates. They need to learn to contact providers when decompensation occurs or they notice any change in significantly in their behavior. Supported employment and education programs are available in many communities. Helping people return to work or school really improves not just functional outcomes, but also their self-esteem and social connection. So most communities have access to these programs, like supportive work programs or vocational rehabilitation for the disabled, like at Mass Rehab. These are valuable resources in integrating the patient into the community. Many colleges have supported learning programs to help patients enter a tailored education program. Here we have one in Cape Cod called Project Forward, where there's a part-time admission to college with a tailored approach to people with special needs. Referrals may be made for many of these clients to substance abuse programs because often they self-medicate with street drugs. Cannabis, stimulants, and hallucinogens can worsen or trigger psychosis. So addressing substance use is an essential part of their care. We often forget about spiritual and meaning making. When we respect and work with a patient's cultural and spiritual worldview, it not only reduces stigma, but can also support better treatment adherence. Integrative psychiatry recognizes that practices which foster resilience, hope, and a sense of connection, whether that's prayer, meditation, ritual, or community, can be just as important as medications or therapy in sustaining recovery. This is an often overlooked dimension of integrative psychiatry. We should encourage families to include patients in holiday traditions, take them to their place of worship. Group homes and other shared living programs can be encouraged to do the same. So the importance of collaboration cannot be underestimated. Psychosis care works best when it's not just one provider, but a whole team working together. Integration of services. Treatment plans that are developed should be shared across both medical and clinical providers, so everyone is on the same page. Effective communication and shared planning. Regular communication has to be accessible to all team members and ideally formalized at the very start of treatment. Improving outcomes through collaboration. Teams should agree to alert one another when symptoms begin to worsen. That kind of early communication can prevent relapse and keep patients stable. In short, coordinated care means integrating services, keeping communication open, and supporting each other to protect patients from relapse. Howard?
Thank you, Karen. One of the most important shifts in care is moving away from focusing on what's wrong with you to what matters to them, to our patients. So we need encouragement from the whole team. Patients with psychosis should be encouraged to live healthy, fulfilling lives because they can through community activities, social family life, and personal interests. Now, the role of the prescribing team, I'll say again, it can be specific. For example, prescribing exercise, adult classes, community lectures as part of treatment. The role of therapists are integral to that. They can build on this with homework, accountability, and making sure patients have the support to actually participate in the things they enjoy. How to make it work? We can use techniques like motivational interviewing and barrier removal to help patients engage more fully in meaningful activities. In short, flipping the script means helping patients build a life worth living, not just treating their illness.
In short, the earlier we intervene after the first episode of psychosis, the better the long-term outcomes. Early intervention requires more than just medication. It's a coordinated wraparound effort. First, ensure the basics are in place. Clinicians should always assure that the client's connected to an appropriate medication management provider. Try to use evidence-based therapies when applicable, and connect to strong case management. Care should be coordinated through HIPAA-compliant communication amongst all providers with formal collaboration from the start. Community and practical support should be in place. We need to make sure housing, family support, financial assistance, and insurances are in place for the patient because stability outside the clinic is essential for recovery. Again, access and availability to 24/7 support when crisis emerges. High incidence of suicide amongst patients with schizophrenia are the reason why we have to emphasize the importance of safety planning. From large-scale studies, lifetime suicide risk in individuals with schizophrenia is very high compared to the general population. 5 to 10% of individuals will die by suicide. 20 to 50% of patients with schizophrenia will attempt suicide at least once compared to the general population, which is 10 to 20% higher. Thus, the importance of safety planning is emphasized here. At the end of this presentation, I'll give you an example of a safety plan that you can use with your patients. Holistic recovery. Finally, recovery isn't just symptom control. It's ensuring access to social participation, therapeutic groups, and removing barriers so patients can live full, connected lives. In short, effective care is holistic medical management and therapeutic interventions. So here's an example of what a relapse plan or safety plan should include. It should include what has triggered relapse in the past, any events or stressors. Know the early warning signs. List those symptoms that signal a possible relapse. Also, indicate any coping strategies or actions that help calm the client, what the client can do when early signs appear. Who can help and what specifically they should do should be listed somewhere with the caregiver or case manager or whoever's living with the patient overseeing their care. Crisis threshold. This means we need to determine when is it serious enough that the client needs to be hospitalized. Having delusions or hallucinations is not necessarily a reason to go to the hospital, but when the client becomes irrational, difficult, irritable, is displaying dangerous behavior to themselves or others, this is a time to contact the emergency or urgent medical care. Either dialing by 911 or you can go to your clinic director and try to arrange for a Section 12 with a provider or someone on your team. So these are just some resources I put at the end of the presentation. NAMI is the National Alliance for Mentally Ill, which is nationwide and has a helpline. And you can text NAMI to 62640 if you're looking for a way to connect families to some of the support groups that they offer. There's a National Mental Health Crisis Line, which is 988. Easy number to remember for our patients if they can't get a hold of anyone. Know your local Department of Mental Health and their number and how to reach them. The National Institute for Mental Health has many brochures and fact sheets that you can look up on their website. Know the behavioral helpline in your state. For instance, in Massachusetts, it's this 833 number here. There's many resources for finding treatment centers across the country at findtreatment.gov. And again, I mentioned these manuals for CBT are available and highly recommended for CBTP. The beckinstitute.org covers online courses for CBT and application for psychosis. So now we're ready for some questions. Hopefully we can provide you some answers. And if anyone wants to share experiences, challenges, or insights.
All right, so I want to answer Asha Kominapali's, I hope I didn't butcher her name, question. Are the percentages based on in the USA or all over the world? So prevalence of schizophrenia, good question. I think worldwide, most large epidemiological studies would show 1% approximate lifetime globally. So 1 in 100 will meet. In the USA, it's very similar. They say around 0.25 to 0.64, 0.65. So nevertheless, close to 1% lifetime prevalence. But the numbers may differ across different countries because of access to care, cultural differences, their screening process maybe different, but generally it's going to be close to 0.5 to 1%.
Thank you.
You're welcome.
Any other questions or concerns?
There's a question in the chat that says, are there any strategies you found helpful to support clients to manage medication side effects such as memory issues, brain fog, weight gain, etc.? I found clients get very frustrated and disturbed by these symptoms, even if they're committed to the treatment.
Yeah, I think so for memory issues, aka brain fog, sometimes, well, one, we can reassure sometimes that this can be common. So we encourage maybe tracking it, like maybe journaling or using an app to note when side effects are worse. That would be helpful for us. Sometimes timing adjustments of the med. Maybe if they take it at night, it'll be less, causing cognitive issues. What else? Cognitive supports, perhaps. Phone reminders, pill organizers, anything that can graphic organizers, right? That's for the brain fog. For weight gain and metabolic effects, right? Yeah, you want to monitor it too, through the primary care, or the psychiatrist should monitor. Nutrition counseling would be good, I think, and movement. So physical activity, that exercise prescription. And then if it's really bad, you can have collaborative plans. If the weight gain is so severe, you can review options with the prescriber. The prescriber can add maybe, I don't know, a GLP-1 or metformin adjunct, or considering an alternative med with lower metabolic risk. So we need information too. We're happy to get those information.
We have a question from Alan Cole.
Hello, excellent presentation. That was very informative. Thank you. My question has to do with, I want to hear your thoughts on coordination of special care teams when, say, the client is getting a monthly injectable, but not much else is happening in terms of exercise, all the things that we talked about, you talked about. How do you approach that kind of sort of stubborn situation where there is no movement except for the monthly shot?
So let me just say, the squeaky wheel gets the grease, and it's usually the clinician. We are the prime advocates for our clients. And I more than once have had to call up the caseworkers and let them know from the beginning that I expect them to be involved. I expect them to participate. I expect them to help them to commit to many community resources that are out there. It's really amazing how many resources are available to clients, even funding for things like yoga classes and their own personal resources that they may have that are in bank accounts that they don't even know about. And so it's important for the clinician to stand up for that client, because sometimes you're the only voice that they have, and talk to these workers. Some of the DMH workers, and of course their funding has been cut, but they carry like 200 cases. So it's important that you speak up and advocate for them, because there's resources out there that they can take advantage of.
Sounds like you're thinking about how to collaborate with specialized care like psychiatry, primary care, specialty clinics for a client who is on an injectable but no movement. I think so. The more heads or the more brains, the better. I think with proactive communication, we share structured updates with the prescriber, not just about side effects, but also side effects that are not there. We should be using standard tools like AIMS, right? The Abnormal Involuntary Movement Scale, to document baseline and ongoing monitoring. But then also collaboration strategy would also include looking at it at the multidisciplinary lens, collaboration with dietitians, right? Primary care, therapists, and that would hopefully ensure that the injectable plan is part of his holistic care. And then client, give power to the client too. Shared monitoring. I hope we can encourage the client to participate in regular check-ins like weight, blood pressure, mood, cognition, so they feel they're in control of their treatment journey as well. So
Thank you.
We have a question
welcome.
from Deirdre Down Pizzuto.
Yeah, I just am thinking a lot about the notion. I've been a firm believer getting people engaged despite whatever's happening and keeping your routine. I'm a fee-for-service clinician, but I've been in special education for like 37 years, working in a therapeutic day school. And I can't tell you how many times that parents, kids, they they get permission, they get medical notes to stay home, take breaks, relieve the pressure. And I feel that that's been a challenge. Any tips? Like, how do we get our colleagues in all walks, and the parents are scared too, right? Like, they keep the kids home because there's lots of reasons. They're afraid mostly. But any tips around, I don't know, around that piece of it?
Well, I think what you're referring to is that it's better for clients to engage than not engage in community education and supports. And it has to start with the family psychoeducation piece, which I mentioned early on in the training, that this should be one of the first sessions. If families are involved, let's use them to support our values and our treatment recommendations. That's when things should be discussed about not giving in to inactivity, and that activity is important for positive outcomes and the prevention of relapse. So I think I hear you, Deirdre, and this is typical, I'm sure, with younger children, but we mostly see this with even older people who refrain from going to program when they should be going to programs and day programs, et cetera, et cetera. So getting support from community providers and the caregivers as well as family members is key from the get-go, and explaining how important it is to not refrain from activities.
I would love you guys to present this type, school counselors would benefit so much from this, even, in some of the private schools, the collaboratives, or, those providers they're captive audience, right? Like, these kids, they see a lot of these kids, and I think this would just be great. I don't know if there's a way to get this out to a whole other group of people that have direct experience with the kids. I think this could, children and adolescents, and we have like 18 to 22-year-olds too. So
Right.
I might be calling you to see
Okay.
about reaching out because I'm right in Massachusetts, in southeastern Mass. If that's okay, pick your brain a little bit.
All right. Thank you for the suggestion. I think it's a great idea. Any other comments or questions? Betsy?
I just wondered about if there's any other strategies for clients that have auditory hallucinations that are like very controlling of them. And I don't mean to do anything to harm anyone or themselves, but controlling, like telling them when to take a shower, what time to eat, and that they also don't almost like want to give up the voices because they also feel like they're being protected by them. And I have a couple clients that I just struggle with because of course they believe they're real, and you try to walk them down the path of they're really not, but they almost don't want to give up the voices. And any other strategies for how to deal with that?
Howard, do you have any answers? Otherwise, I'll.
I think first, right, you want, certainly this is a common tricky clinical situation. They hear voices, they're controlling or prescriptive to as well. First key principle is well, you want the medication first to work for them to gain insight. But if it still is happening, I would probably start with validation, curiosity, and even collaboration, as long as you're safe. Uh, I acknowledge that the voices can feel protective or meaningful as well. Um, I think there's a group now that meets from the our previous session. Someone presented that there's a group of patients who hear voices and they get together. Other principles, harm reduction over coercion, like we prioritize maybe safety and function over eradicating the voice. So we just
Mhm.
reduce the risk, especially the command hallucinations, while supporting autonomy. Sometimes confrontation, is not good in these types of people, especially if there's still no insight or limited insight.
I would also add that I've had a patient like that who, no matter what I did, I was getting a little frustrated, but I did have him list all the things that he can't do because he's letting the voices control his lifestyle. And it was a pretty long list. And it was sort of enlightening for him to see that there were other things that he was missing out on that could make his quality of life so much better. So that's just a little exercise that you can do with that person to just try to show them the barriers that these voices that control him are creating.
Thank you. Thank you both.
You're welcome. Okay. I believe Karen mentioned that the form that you'll need to fill out to complete your CEUs or CMEs will be in the chat. And you go ahead and do that. You can, I did miss it. I think we have everything covered here. I don't think we missed anything. So if you need to fill that out to get your CMEs, it was listed at 4:45 in the chat. So it's right there. It's like a SharePoint kind of form. So just click on that link. And if you have trouble opening it, just download it or let me know and I'll resend it to you. I'm going to put my email and Howard's in here, so in case you need to contact us for further questions. And I know that the PowerPoint slides will also be uploaded into the chat.
So in closing, I hope that the takeaway is that treating psychosis is never just about reducing symptoms. It's really about relationship. Our treatment modalities, will certainly be different in 50 to 100 years, but the relationship is what sustains and is the one that's there for us to give them meaningful, connected, and resilient lives with the help of a coordinated care team. So on behalf of both of us and Karen too, Liliana, we want to thank you for your time, your attention, and for the work you do every day with your patients, families, and communities. Your commitment truly makes a difference. So thank you.
Thank you and have a nice evening.
Thank you.
Thanks. Appreciate it. Bye.
Bye-bye.